she could. Whoa.
Yeah.
There's a
Ooh,
dimmer.
yeah.
Turn it off and then turn the dimmer one on. There you go.
And then turn.
And then
There we go.
There you go.
Ooh.
That, yeah, that'll work. Okay.
Mood lighting.
Let me do the Facebook Live.
The mood lighting.
You need to what?
Facebook Live for our
Oh.
personal, for our Facebook. Are you
Gotcha.
okay
No,
doing that?
that's fine. I'll have to watch my language, but that's fine.
No,
It's a
it's
private.
just
It's a
a
private. It's a
Facebook.
private Facebook page just for.
Pretty sure anybody that has been on a ship that I have been on has had plenty of expletives. It should be alright. Am I right? Am I right, guys?
Yes, you are.
I'm sorry. I'm sorry.
Never once heard a curse word on this unit ever.
Never.
Not in the last 5 minutes.
Every time I go to front, like, I'm just like, don't have my. Oh, I'm sorry. I'm sorry. Oh, there's some chairs.
Oh, I'm okay, thank you.
I won't bite anybody. I promise.
Okay. All right, so I was asked to give my chest x-ray lecture, and I've kind of revised it because this was originally a trauma chest x-ray lecture. So I've pretty much gone to putting in here. So this is a normal x-ray. Trust me, it's normal, okay? We're gonna go through each piece of the x-ray in a mnemonic. So here's an overlay of what all can be found in the chest x-ray, okay? As far as normal anatomy goes, okay? So as we're going through, my mnemonic to remember and be able to read a chest x-ray is called rib cage, okay? So we want to look at the radiograph quality, the inspiration, the bones, the cardiac silhouette, the airway, which includes the lungs, the gastric bubble, and any extras that might be in the chest x-ray, okay? So radiograph quality, you want to check the alignment, the positioning of the patient. Are the clavicles symmetric? Are they rotated at all? And how dark is the x-ray? How light is the x-ray? If it's under-penetrated, it's going to be really light. If it's over-penetrated, it's going to be extremely dark, and you won't necessarily see everything that you need to see. So the first, again, as far as inspiratory effort, 9 to 10 ribs is the best inspiratory effort. Usually when I say they're under-ventilated or they're not taking a deep breath, it's because we're seeing only like 4, 5, 6 ribs on the x-ray, okay? All right, so bones. Everybody wants to go to what's the center of the chest, but when I talk about looking at the bones, you want an x-ray that can actually see maybe some of the arms, the clavicles here, the scapula here, the vertebrae, and then actually look at the ribs themselves to see, is there any density issues, or are they osteoporotic? And oftentimes if you see that they've had a shoulder replacement or they've had something else go on, you will figure out that they've probably got osteopenia or osteoporosis that led up to that. You want to look and see if if the clavicles are in alignment. So you want to see if the head of the clavicles frame out your vertebral column, okay? If they don't, they're rotated. Something's gone, they're either this direction or they're this, or they're, kyphotic from that aspect. And I don't have any of those x-rays as far as the kyphosis goes. I took most of those out. But again, you want to look at all of your bones before you get into looking at the content in the center of the chest. So, C. At this point, you're looking at your cardiac silhouette. It needs to be midline from that aspect. What you guys oftentimes will see is that it shifts or that it's larger. It's going to be different on your PA and lateral than it will be on your AP films. Most of the things that we do, we shoot as a portable chest x-ray, so the plate goes in the back and we're shooting the beam this way. When you take a portable, or when you take a regular chest x-ray, PA and lateral in the department, the plate is here and the patient is standing up against the plate, so the beam is coming from the back, okay? So it'll look a little different. The chest will look a little bit more compressed and the cardiac silhouette can be a little bit more wide from that aspect. But it's usually going to be about 1/3 of the chest in size compared to 2/3. So you want to make sure that they have sharp borders that you can really see, and we'll see different sizes of the heart as we go through. You want to look for the aortic knob or knuckle, which is usually going to be up in this area. The pulmonary arteries are going to sit right in here. And then you want to look right in this space here. This is the retrocardiac space on the left-hand side. And a lot of things can be hiding there as well. Again, this is a picture of like an aortic dissection, okay? This is much wider mediastinum than compared to our previous x-ray where this was a narrow mediastinum, okay? So this is the mediastinal area. You really can't see a lot and tell a lot about anterior, posterior, superior mediastinum other than the size right there, okay? And then of course this is an extra. What's that?
That's a watch.
That's a wristwatch. Okay, all right, gotta be situational awareness, like I say in EMS. Okay, so airway and lungs. So you're not looking just at this airway here and you're not looking just at the lungs. So this patient is actually intubated. The carina is sitting right there, okay? So the trachea comes down and splits off and goes over to the right side, goes off to the left side. And of course, this is the left lung and this is the right lung when you look at a chest x-ray. So you want to look at the hilum, which is the center here. You want to look for any infiltrates, nodes, masses, and if it's higher on one side than the other. What's under here on this side, on the right side? The liver. So the liver, gallbladder is over there too, but the liver actually is the thing that pushes the right diaphragm up higher than the left diaphragm, okay? And it's surprising because you actually have 3 full lobes of lung on the right side. You have 2.5 lobes of lung on the left side because you've got the upper lobe, the lingula, and the lower lobe because you got to make an accommodation for the cardiac positioning in the chest. Okay, you want to look at your diaphragms. Are they clean and clear? Do they look like a half moon size there? Okay. You want to see if there's any flattening. What if it's flattened? What does that tell you usually? Somebody who's got COPD or bad emphysema because their diaphragms don't work. Their lungs have pushed their diaphragms down and the diaphragms can't move back and forth as easily because the lungs have pushed them out of the way, okay? Look for just clarity of overall, and then you also have to look at the pleural space, the space between the ribs and the lungs here to see if there's any fluid, any air, and you have to look all the way up to the apex. So this is rib 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so good inspiratory film, so you've got good expansion of the lungs, both sides. I don't see anything that really looks horrible in that other than the fact that they've got an endotracheal tube in place, okay? And that's not really horrible. Check the lung contours for loss of definition. Again, cardiac borders, you want to look because, again, your pulmonary vessels are sitting right here, and you want to look at the mediastinal margins because things can be hidden there as well. So we'll see examples of this as we're going through. I also like to say divide it into different things. So when you're looking at it, look at here, okay? Are these equal? Do these look okay? Is there something that's not on one side versus the other? And I want you to do it for each one of the segments and then do it from side to side as well, okay? Because things can be hiding and oftentimes we go right for the cardiac silhouette and we don't look at anything else, okay? Look at the vascular pattern and look to see if it's more congested. Is it congested on one side versus the other? And again, I've got lots of x-rays to show you. Look behind the heart, behind the hilum, behind the diaphragms, and at the apices. Okay, gastric bubble. So this is the G in rib cage. This is the gastric bubble. So diaphragm here, diaphragm here. This is below this diaphragm. Even though it looks like the ribs are crossing over it, there's ribs right there, okay? So this is the gastric bubble. This is a breast shadow here, breast shadow here. So is it in the correct spot? Sometimes you will have patients that have dextrocardia, meaning that their heart is flipped, and sometimes their organs are flipped. Sometimes the film is labeled and it's labeled wrong, and so you have to look and see what's going on with the patient and make sure that it's in the right spot, that they labeled it right, okay? Is there abdominal gas down here? Is there free air? Because you can see free air in the under the diaphragms as well, and I'll show you a picture of that. And then we go to extras, okay? So there's a lot of extras in this spot here. There it is. It's not really showing up. So you've got chest tubes here. This is metallic, so this is a bullet trail here. This is a endotracheal tube, another chest tube. We've got something going on up here. You've got a little bit of an apical pneumothorax. These are outside the chest here. So just some examples of some extra stuff that you can see. You also want to look outside the area. So here is sub-Q emphysema, okay? So you know that this guy, because of the chest tubes also, and we also know that there's a pneumothorax here, but there's air outside. And there's a little bit of air in this pectoral muscle, and you need to look up here because sometimes you can see air in the neck as well, okay? All right. Again, you want to look for your lines and tubes, follow them along the course, make sure that so this endotracheal tube, I'm going to just tell you, the carina is here, the endotracheal tube is here, so that's probably going to be about 5 centimeters above the carina. It's just barely in the thoracic inlet when you look at it, so I would probably be telling our respiratory therapy folks, please help me advance the tube a little further. Now the other thing is anytime you move the endotracheal tube as far as moving their head, it's going to cause it to go in deeper or come out. So when it goes down, it comes out. When it goes up, it goes in. Okay? So that's another important thing with positioning of a patient when you're taking the x-ray. Okay? All right, central lines and other stuff. What's going on in this picture? What is that?
Is that a feeding tube in the lung?
That is a Dopphoff tube in the lung.
Yeah, I
Yep,
was
there you
like,
go. Yeah, so that's a misplaced feeding tube. And the hope is that with that, you don't end up having injected anything in there. Injecting air is okay, injecting saline is okay, but injecting tube feeds in there, that'll give them pneumonia. Exactly. So, and remember I talked about flattened diaphragms. Here's an example, a good example of some flattened diaphragms. This patient is an extremis. They oftentimes, when they're severe emphysema, won't have a cough necessarily, potentially, and so that's probably what happened is this tube went awry because they weren't coughing. You can tell that they're an extremis because there's expanded space between their rib spaces, and the lungs are hyperinflated. Okay, so the concern here is that this patient, and there's an endotracheal tube sitting right there, you know, so this patient probably also needs to come off the ventilator and have his chest compressed to see if we can get that to kind of settle out. Okay, all right. So, and then the other thing too is I do a lot of moving and hauling patients. You guys do a lot of moving and hauling patients to various tests and whatnot. So when you get them moved, you need to make sure that their endotracheal tube is in the same place that it was when you left, okay? Or that their lines and tubes are in the same place that they were when you left. Your swan is in the same place. Because invariably when we take them on a transport, we're going to end up misplacing something or dislodging something, and then that becomes a serious problem. How many times have we lost central lines moving them around, even in the bed, with regards to radiology coming in and moving them? So again, we just need to make sure that if you need a comparison film, let us know, and you guys are good about that when you think that something's moved and you want to make sure that it's still in place. Okay. What extra is hiding in the chest x-ray? Okay, you gotta have some humor. Okay, all right, so looking at this chest film, it's a relative good quality because you see the entire apice of the lung to the base. You see side to side, so there's nothing cut out of there. It looks like it's mid-position, the bones look like they're okay, they're a little bit hypodense from that aspect. You're looking at some flattening of the diaphragms, it's a little bit more expanded. Here's your wing bone here, here's your wing bone here, those are overlie shadows from that aspect. So this is a patient with what? Patient's got a pneumonia. This is sitting right here, okay? I don't see anything else when I look at, I mean, his cardiac silhouette looks good. There's a little bit of air here that tells me that this is probably a left lower lobe pneumonia. There is not any density behind the diaphragm or behind the heart silhouette here of significance. There's a little bit of air clearing, so that makes me think that the lingula is safe. It's just probably a left lower lobe pneumonia. Now, the vascular pattern, it looks a little bit more busy, for lack of better terms, okay? A little bit more fluffy, so there's quite the possibility that they've got some fluid additional there going on, but the primary problem is sitting right here, okay? All right. This is a little bit more of a pneumonia picture. It's not a good film. It cuts off the apices, okay? So when your radiology tech comes in and says, you want me to shoot an extra film, when we're looking for, say, line placement or tube placement from that aspect, if I've got enough information, I probably won't make them do the repeat x-ray. But if you're looking for a daily comparison, you may need to have that, or if you're suspicious that they've popped a hole in their lung and they've got now a pneumothorax, and you can't see the apices, you really don't know. And these are patients too that may have had a chest tube in and they've taken the chest tube out, and you want to know about whether or not they've developed an apical pneumothorax, and you're not going to be able to see it because it's a poor quality film. It's a little underpenetrated as well because you don't see the vertebral bodies as well. This one's got actually a trach, so when you look at this particular patient, this is a ringed tube rather than a regular endotracheal tube, which tells me that that's a tracheostomy tube, okay? You have to really get up close to look at it, but there's this stuff here is part of all of the apparatus for the breathing from that standpoint. This is the leads on the chest that are outside of the chest, okay? But this is a pneumonia here. This spring here is part of the apparatus that's outside of the chest. Okay, so this is a reasonably good film. You can see a lot with it. You don't see any real narrowing of the trachea. It comes down to both sides. It's mid-position. There might be a little bit of lordosis where they're kind of curving over a little bit here because their collarbones are down and not as high as they usually are. You don't really get much of their humeral heads. Their scapular here, they've a little bit lighter there. You've got a gastric bubble underneath the diaphragm, but it's kind of diffusely hazy, would you agree? Both sides are involved. This is a picture of ARDS, okay? This is what a typical COVID patient nowadays could very easily look like. Okay, compare this and contrast this to this next film, okay? Very similar as far as the haziness goes. But what do you see differently? When you look at it, it's a good film, reasonable. We don't have the apices as well. It's a little bit flattened with regards to the clavicles. The clavicles aren't as curved as they should be. So kind of sitting upright and probably back this direction. But what do you see different here that you didn't see in that previous film? And I'll go back one film, okay? Pretty diffuse, pretty involved. This film, it's more centrally located. Remember when I said look at them side by side, look at, so if you took this out and you looked at just this area, is that pretty well equal? It is. And then when you look here on both sides, it's pretty well equal. This is a picture of heart failure. I could not find the classic Batwing film because it's actually a film that I have that I have never been able to get copied into a slide, okay, or into a picture. But this is pulmonary edema. So this patient is not intubated, okay? There's not any extra tubes. There's not any real narrowing of his airway there. It's a good expansion film otherwise, it's just that they're full of fluid. Okay, this is the patient that you would see, and you'd probably put on some BiPAP for positive pressure and see if you can get this to reverse with diuretics as well. Okay, so that's the difference. And again, these are leads on the outside of the chest. Okay, so you guys might very well see somebody like this. Okay, all right, so busy chest. Again, snaps on the outside of the patient. Those are not bullets. I do have some that have bullets, true bullets in there, because I've taken care of those patients. But looking at the film, it's a relatively good film. You see that it's a little bit of lucency here, so probably a little bit of osteoporosis. Everything lines up here. You've got a little bit of apical capping. There's something up here that isn't on both sides. It may be a little rotated as far as this is off, but the big elephant in the room is this is white compared to this side, okay? Pacemaker here, heart is in this mishmash of stuff, but you've got all kinds of staple lines here. So this is actually lung here, this is pleural space here, so they've got a pleural effusion, so they've got fluid, okay? And they've got a staple line, so what does that tell you? They may have had some kind of lung surgery, okay? It could have been a bolectomy where they had, you know, the lung reduction surgery for bad emphysema, but that's where, and it doesn't make sense with all the staples otherwise, other than to be maybe a bolectomy or a lung reduction surgery, because again, you kind of see the stump of the bronchus over here, and you see the air here, which is the actual lung, but that's just the edge of the lung. Okay, when you look at this side here though, again, it's hyperexpanded, okay, diaphragms are down, and you notice on this one, the previous one, there's a shift. So they're not expanding that lung, so that is being filled up. So it's not a tension type of a picture here, okay? This is what's gonna happen as a result of this lung surgery. They may need a chest tube to evacuate, but that may be all they get after a lung reduction surgery, okay? I've seen lung reduction surgeries be better from the aspect, you know, where they re-expand and they fill the space, but this may be early post-op. Here, I forgot to even mention, is the PICC line. See the PICC line coming down? And you can tell that that whole carina and mediastinum is shifted. So going back to this film here, this is an actual pneumonectomy, okay? You cannot do anything to this. If you try to take fluid out, it's just gonna fill the space again. So it's a moot point, it's just gonna be that way, okay? Because something's gotta occupy that space. We don't put a styrofoam or something in there to replace the lung. It sits there. And you can tell because there's the stump of the mainstem bronchus, and see how this buds out and goes like a tree with branches. So they're just gonna chronically have that, okay? Gastric bubble, they've got some ileus here, there's some colonic stuff down here. So gastric bubble here, colonic stuff here, so yeah, this is somebody who's pretty sick. Okay, now, this one's a little different, okay? What do you see up here, other than the white up? I get it. So, see, I was talking about the ringed tube, venotrachea. This is a tracheostomy tube. It's a little kinked, okay? So, you can see the angle there. What do you think happened to this patient? Mucus plugging. So this one, two things, probably mucus plugging, may have a pleural effusion as well. So this would be somebody that I'd want to bronch. I'd want to square up their trachea tube, okay, tracheostomy tube, but I'd also like to know if they're full of mucus, and this was where I would go suck snot, okay, to see if I could open up that airway. Because again, you see the shift, you really don't see this budding off, so there's something going on in there. And more than likely, it's going to be that they've got a mucus plug in there, okay? All right, and I don't see a lot of extra stuff. There's a PICC line there too.
It looks like the trach tube is like in the right lung, it's angled that way? Is it just because it's kinked that way?
Yeah, it's just kinked. Because the tube is actually sitting here and the carina is sitting right about here. So it's not main stemmed, and I'll show you a picture of main stemmed in just a minute. But it's kinked, and my guess is how we've had that over in TCC where the tube kinks off and nobody's paying attention, and then they had a whole bunch of secretions, and then we end up with them, dropping their sats and getting hypotensive because they're having issues with this lung blocking off because of the mucus. So, but yeah, it's trending this direction, but I think that's where the vent setup is that it's just pulling it that direction on the right. But there's your PIC line too, and it's coming down and going there. And okay, all right. So low lung volumes compared to some of the other ones that we've seen. Okay, you're looking at this. It looks like overall it's a pretty good film. You've got a little bit of narrowing up here of their tracheal tube. Okay, what else do you see in here? Cardiac silhouette's a little large, but that, again, when you decrease the volume that you're ventilating, and this is a AP film, your cardiac silhouette's going to be a little bit larger. They've got a chest tube here, okay? They've got something going on in this part of the lung, so you don't see crisp, clear areas of the cardiac silhouette on the left-hand side here. Their diaphragm border, however, is pretty clear. The other thing you see is they've got sub-Q emphysema, and they've also got sub-Q emphysema up here, okay? So this chest tube goes, so it's going in the back, down the gutter, back over here, but it's kinked, okay? So you're not getting the expansion or the removal of the air because you're kinking right at that eye hole, right at the side that should be in the chest anyway. But it's not effective, okay? So we would want to pull that chest tube back and let it re-expand and be able to help us re-expand that chest, okay? All right. Okay, this is a problem. Okay. There's a lot of things going on in that
Is that
chest.
stomach, like intestinal?
That's tube feeding.
That's tube feeding.
That's tube feeding. Sorry, the nurse manager from the other unit. Okay, so with this, again, you see the shift, okay? So the heart silhouette's over here. That lower lung is compressed. This is the feeding tube. They've got an airway. They've got a central line, so they've got a subclavian central line. And the reason that I know that is you can see the ports sitting off here, okay, versus the PIC line, which you're not really going to see the ports unless you get that arm in there. Calcified aorta knob there. But yeah, this is a malposition of the feeding tube, okay? And that probably had tube feeds that went into the lung, okay? So you're seeing some of the air here. There's some air bubbles in there. This is actually below the diaphragm here. So you don't see a clear, crisp diaphragm, and they could have actually, maybe we've had feeding tubes go through the lung and into the pleural space. We've had one just recently. Okay, so when you're looking at this, looks like a pretty good film overall. Maybe, I mean, because you can see the vertebral columns, you can see the whole expansion of the lung. It's a little bit deep here from that standpoint. This side is down where it normally should be up. What are we seeing here? Sorry, guys. I was hoping somebody would cover me for a few minutes, but. You keep looking. Time. Okay, I will get to him as soon as I'm done with my lecture. Thank you. Bye. Okay. All right, so down and dirty is this patient has a pneumothorax. Okay. The lung actually is right here, if you were up close to this film, okay? So here's the lung here.
Collectively,
This is all the way out, because you can see lines all the way out. This is called a deep sulcus sign. It's not the absolute best deep sulcus sign, but this is what you see. There's clearing in this corner because the lung itself is sitting right here. So this is a pneumothorax that we would want to put a chest tube in, okay? Because they're not going to clear that easily.
So that deep sulcus line, is that something you would typically see with a pneumothorax?
You can see it with a pneumothorax, and sometimes that's the only thing that you'll see with a pneumothorax. Because if it's an anterior pneumothorax, you'll be able to see the full lung, and it'll rattle your cage because you're like, you know that there's something going on with them. Their peak pressures are different, whatever. They're hypotensive, whatever. And you look at it and you don't see it because the lung is fully expanded. And sometimes you'll just see that slight sign, or you'll see some pneumomediastinum or something along those lines, and that'll be enough to tell you that something else is going on and that you may have to do a scan to make sure that it's where it's at, so that you also position it right. Okay. This is a problem. This needed a chest tube yesterday. Okay, but this is essentially a tension, and this is a tension in a PD patient. Okay, but they also have this going up, which is their central line. Okay, so they've done a femoral central line to put in, and then you can see there's their feeding tube going in, and it never reaches beyond that because of the diaphragm being compressed. Okay? All right. Tension pneumothorax. Okay. But I want you to also be able to see what, again, as I was talking about, looking at this chest x-ray, I know that there's a pneumothorax somewhere in there, but you can kind of see lung stuff all the way up, both sides, right? But you see the sub-Q emphysema, you see the pectoral muscles being aerated here because the air is going to get out whatever way its least resistance goes. You can almost see some supraclavicular air there. So you know that there's a pneumothorax both sides there. This is actually a trauma film, but that at least gives you an idea of some of the things that you can see when it's an anterior pneumothorax and you don't necessarily know otherwise. Okay, so you know that something's going on. Do you put a chest tube in both sides? Probably. But where do you put the chest tube? Do you put it up here, or do you put it on the side? What's going to be your best? And that's sometimes where you need to get a film to be able to determine where you're going to put that chest tube. Okay? All right. So, you see a white arrow. It points exactly to it. It's not a great film. Again, it's not all there. But what they're pointing out is that you can see that there's air in the pericardial sac. Okay, so this is a pneumopericardium. Another example, okay? Okay, this is a pneumomediastinum. And the reason being is there's a clear stripe of air that goes pretty much all the way up. So that's air in the mediastinal area, okay? It's not compressing on the heart, and it's leaking down. So it's either going to be that it's gone down, okay? So sometimes when a patient who has asthma, say, pops a bleb in their airway, and it's central, it's not a pneumothorax, the lung doesn't go down, but it stays central, it's going to go down through the diaphragm potentially, and you might have air under the diaphragm. Reverse scenario, you may have had an abdominal procedure that had air in the abdomen, and it's going to rent up that direction, and it's going to rent up through the mediastinum because your esophagus goes through a little hole down here in your diaphragm to be able to communicate. So that air is going to go whatever way is, again, the path of least resistance. So you may have pneumomediastinum and free air under the diaphragm, but that's what free air looks like. That's not a gastric bubble, that's free air. And here's a little bit more pictured here, and you can kind of sort of see there's a stripe there of air going down. And again, this is not a great film. You see supraclavicular air up here, so you know that the air is going this direction, okay? But they've got air on the diaphragm as well. Okay, so what's wrong with this picture? Looks like a pretty good film overall, right? Pretty square on, you can see the vertebral bodies, the heart border doesn't look too bad. This is a little fluffier from that standpoint. The pulmonary vasculature is a little bit fuller, probably has some sleep apnea or something along those lines. Where's the gastric bubble?
Not there.
It's up. Is it herniated?
That's a hiatal hernia.
Okay.
Okay, so that's what one looks like. That's a little bit more exaggerated than we see, but that's what a hiatal hernia looks like. Okay? All right. We get Ivor Lewis cases in here, right? So what had they done? They basically pulled up the gastric stump and reconnected from that aspect, okay? This is actually a Boerhaave patient. Boerhaave meaning that they retched and then ruptured their esophagus, okay? So you're gonna see air and you're gonna see salad down here of whatever was in their stomach when they were retching, okay? So this is a pneumothorax, but this is also fluid in here from that. So, and they've got some free air, right, pneumomediastinum right there as well. So this probably needs a chest tube to evacuate. There's their stomach bubble there, okay? All right, what's this? So it's a good film. It's fairly centered on. You're seeing a little bit of shift of the cardiac silhouette to the right, which is the left-hand side when you're facing the film, but over there, okay? What's over here?
Nothing. Another collapsed lung.
No, it's not a collapsed lung. The reason being is what are these? Those are Haustroll markings. This is colon. So they've got a ruptured diaphragm. You don't see the diaphragm here, and the colon is up in the chest. Okay?
Where's the lung? Is it compressed?
It's compressed.
Oh.
The lung is
Right
sitting,
there.
the lung is sitting
Oh
right
my
here,
God.
but the colon's
That
there.
is a problem.
That's an issue.
Okay?
Whoa.
But I would not stick a chest tube in that. And some people have, because they thought it was a pneumothorax, and it's not. It's basically a ruptured diaphragm, and you can tell that because you've got Haustroll markings there, the ringed markings of the colon. Okay, all right. But to differentiate, this is a pneumothorax. This is actually a trauma patient. Look at how these ribs are this direction compared to this side. Ribs are all in alignment here, so these are multiple rib fractures with a pneumothorax. Okay, so this patient's going to need to have a chest tube. They might also need to have,
Hit both buttons.
might also have to have that. And Dr. Cacciatolo actually does some of that. Those are rib plates. Okay? So those are the titanium bars and screws that go in there, and you can see that there's a chest tube through there. There's a lot of other stuff on the chest that are outside things from that standpoint. There's another chest tube over here. There's your staple line where they went in to do the surgery. But that's what those look like. That's what a rib plating looks like. Okay, guys? All right. Now, we've also had some folks that have had problems with their sternum, correct? So that's sternal plating. Same kind of principle, it's just pulling it all together to make sure that it's kind of stays stable and stationary. Okay? Okay. All right. What's wrong with this picture? Looks like a pretty good picture, fluffy woman like me, but she's got a tube in the wrong place. Where's that tube? It's a right main stem. Okay, and I know it's hard to see, but here's the carina basically here, and this endotracheal tube is going down the right main stem. Okay, all right. This is what happens if it stays right main stem for very long. Okay, so you can see there's kind of sort of some air bronchograms, and I know it's hard to see, guys. I apologize. They've got a feeding tube down here. But this endotracheal tube, there's the carina right there. That endotracheal tube's at least 2 or 3 centimeters down. So that has to be retracted, and we have to probably go suck snot to re-expand the lung. Okay. What's wrong with this picture? It's a fairly good picture overall, right? It's a little underpenetrated maybe. It's a line, exactly. So the line comes in, goes across, and goes back this direction. So that's gonna have to be repositioned, okay? And sometimes it will cross over depending on how the vasculature is running. And it's not necessarily an arterial line, it could be just a venous line, it'll go to the other side. Okay, but that's what you're seeing there. Okay. A little bit of hyperexpanded lung there.
Are those implants?
They are. They are. But I wanted to show you that in difference to that. Okay? That is not an implant. You kind of see, sort of see brush shadows there. What that is a lung tumor.
Oh.
Okay? So go back. These are outside the chest wall. Okay? And you can actually see kind of the lines there of where that is. And you can see that this is inside the chest. Okay? So that's a pretty bad situation. Same kind of hyperexpanded lungs though. It was just that this is inside the chest. Okay. This is another picture. I'm going to go right for the bang for the buck. It's a lung nodule sitting right there. But there's the aortic knob. Cardiac silhouette is skinny because this is a COPD patient. Diaphragms are flattened like we talked about earlier. This is a hyperexpanded lung because they're probably in extremis with ribs that are wider than they should be as far as the distance between them. So this patient needs to have that looked at. Okay? All right. What's this? Where's the heart? This is an asthmatic patient. This is an asthmatic patient in extremis, and the heart almost disappears. It's actually compressed that much because the lungs are so ballooned out. And what this patient needs to do is we need to stop them from breathing as bad as they are, compress their chest, and their silhouette will come back. Okay? The heart has not been taken out. It's just taken over by the lungs. Okay. All right, what's this? Cardiac it's a poor picture, I get it. This is actually a picture of one of my patients that I previously have taken care of.
What is that?
That's a left ventricular hernia or ballooning out. Okay?
Oh, that's weird.
You don't see that too often, but when they have had the big MI, the LAD, the left main that hits this side, that ventricle can get really thin and it'll balloon out like that. That's not apical ballooning syndrome. That's not the broken heart syndrome that we talk about, the octopus heart type stuff. This is actually injury to the myocardium, and the myocardium has expanded and ballooned out. Okay? There's really not much that you're going to do for this, especially with the appearance of the chest x-ray. Otherwise, this was an older patient, so it was one of those things that you can't go in and just shave the muscle and put it back together. They were just going to have to live with this. Okay? But they're at higher risk for developing what?
Blood clot.
Blood clots. Mm-hmm. Okay. What's going on here? Correct. So, okay, look at where the label is.
Oh, we're looking at the.
It's a PA lateral.
No,
No.
it's just labeled wrong. It's labeled wrong.
Mm-hmm.
This is dextrocardia. That's not the left side. This is the left side. But everything is flipped, okay? So this is, okay? All right. There's another picture of dextrocardia. So the heart is actually on this side, this aorta. Sometimes you'll have everything flipped. Sometimes the aorta will stay on this side and the heart will be flipped. Sometimes you'll see that your tummy and everything else are flipped, and it just has to do with genetics and in the birth side of things, before birth side of things. Another patient of mine that had dextrocardia, it was always funky to have to listen to her heart on the right side of her chest. But yeah, that's what those look like, okay? All right. We're almost done, guys. What is this?
Is that an enlarged heart?
It is an enlarged heart, but why is it enlarged? It's got a what? Why does it have an effusion?
Tapenade, or what is
Mediastinum's wide. So this is an aortic dissection. It dissected down into the pericardial space. So the cardiac silhouette looks funky, but it looks funky because they've got a pericardial effusion. Okay. Another example of a big aortic, this would be not involving necessarily, or may involve the arch here from that aspect, but you can see that the silhouette, the aorta should go down this direction, and you can see how it's ballooned out. And here's one that is no longer ballooning out because it's ruptured and you've got blood in the chest. Okay. All right, some devices that you're gonna see. Okay, so this is outside of the chest. This is probably pacer wires or something along those lines, right? As far as that goes, that's kind of sort of what that looks like. So you've got an endotracheal tube, you've got a cordis. What's that? Swan, okay. What's this?
Balloon
Balloon
pump.
pump. That's your balloon pump. Got some chest tubes, okay? So the thing I want to show you guys, it's in the right position. So when I come in, usually when I get called and they're starting to develop some renal failure and, you know, they don't look like they're coming off the vent and, you know, we've got them on balloon pump, what is the first thing I come look at? I usually look at the chest x-ray to see a couple of different things. I look for the placement of the endotracheal tube, I look for the placement of the balloon pump. Because as you all know, if the balloon pump migrates down, it's gonna block off the renal arteries, and what are they gonna do? They're gonna get kidney failure, okay? So this is a good placed balloon. You can see it inflated because you can see that, because normally all you're gonna see is the line, but when it's inflated, when they catch it inflated, you'll see the air around it, okay? And this is not wedged, but this is in the proper spot, okay? This would be the time that I would get called, because look at how awful their lungs look and everything else looks kind of crappy too, okay? All right. And this is a little bit more of a, what? This is an Impella device being placed. That's the fluoroscopic view of that. And there's that, and then you've got actually a femoral swan coming in, and that's why I liked this picture, is you've got a femoral swan in, but you've also got the Impella device sitting right there, going across the aorta, okay? Okay. You know something bad's happening. We've got pads on the outside of the chest. Patient is intubated. Patient has a central line. Another Impella device, okay? All right. What's this? Big heart, there are devices in there. Yeah, there's a line of staples. So what else has been on there?
What is that on the right?
Yeah,
This
that
here?
piece of tape.
That's tape.
Yeah.
Okay, so what did they have done? You can kind of sort of see the shadow here. This is an ECMO device. They've also got the Impella in there, but this is the ECMO device, and this is the tubes taped to the chest. Okay? All right. What's this?
LVAD.
Well, there's a pacemaker, but that's an LVAD. Yep. We don't see those out here unless it's the patient that we're shipping off because they already had the LVAD implanted and we're at the stop-off point. But we don't take care of these out here, but that's what an LVAD looks like. Okay.
Does that come with time, just being able to like find the little details, cause
And I'm not expecting you guys to be experts, but I want you guys to be able to look at the things that you need to look at. I mean, how many times do you guys call me and say, is the feeding tube okay?
right.
Can we use the feeding tube? Is the central line okay? If the central line is going towards the heart, that's great. If it's going up towards the neck, that we need to reposition it. So those are the types of things that I want you to be able to recognize. If the patient is in extremis and we order a chest x-ray and we say, hey, take a look at the chest x-ray because we're concerned about a pneumothorax, you can at least see maybe there's air or maybe there's shift or there's something not right in the chest x-ray. And then you can, go from there. Again, I've been doing this, looking at x-rays. I started in medical school in the late 80s. So I've been looking at x-rays for a hell of a long time, okay? And I'm a pulmonologist to boot, so I had to look at x-rays to figure stuff out. I don't get it all the time, but I do know how to recognize quite a bit and when something's wrong and I need to do something about it. So again, this was a cursory look. The main thing is the mnemonic that I gave you at the very beginning, rib cage. It gives you a basic look of how to look at an x-ray so that you don't go trying to look for something that you can't find initially, potentially. You do it systematically and you oftentimes can do that. But you can do that in under 2 minutes by looking at the x-ray, And then if you're looking for something specific, like your feeding tube, or your, where's the endotracheal tube, or where's the chest tube for that matter? Is the eye hole outside of the chest wall, and that's why we're not getting any suction? Or it's constantly bubbling, and the lungs inflated type of a deal. So those are the things that you can at least be able to look at on a chest x-ray and say, hey, we got this, you ordered this is what I'm seeing, can you take a look and confirm what I'm seeing? Okay, or you can say, hey, we got this x-ray, something's wrong, and I still can't put the pieces together, can you look at it or come help me? Okay, but that's what I wanted you to be able to get from this lecture, was a basic way of looking at the x-ray, kind of an organize your thoughts way, rather than going straight to the heart, because this is the heart area, and the lungs have to play in the same sandbox as the heart area. But there's a lot that can go on in the chest, as you all can see. Okay? And I geared this more to your understanding because you're going to see these devices. And I wanted you to be able to see what the devices look like on x-ray so that it's not completely, a void. Okay? This was actually a picture taken from where I trained, my residency program. This was in the heart hospital. This is one of the flight nurses. So. Okay.
I have a question. I saw a term that I don't understand on an x-ray interpretation, peribronchial cuffing.
Okay. So when you sometimes can catch it on end and you'll see some little tiny holes that are like thickened on the x-ray, that's where the bronchus is coming around, and you can actually see that the bronchial tubes are a little more thickened. That's all it means. Nothing in particular. It's just that bronchus is swollen and it's catching it. Okay.
Thank you.
Thank you
All
so
right.
much.
Thank you.
You're welcome.